food anyway, okay? Which is fine. Let's return thanks. We give you thanks, gracious God, for this day, for the chance to gather and celebrate Palm Sunday. Even more so, we're thankful for this chance to gather here and face the tough questions that will come our way sooner rather than later for some. We ask for your presence, for your guidance, for your sense of understanding and wisdom as we deal with the various issues that will indeed come. So bless now this food, bless this fellowship, open our minds and our hearts, our God, for we ask it in the name of the reigning Christ. Amen. Amen. We are especially pleased this morning to have as our guest Katie Griffin, who is with Northern Westchester Hospital, my preferred hospital. I would say that every word here, but my hospital of choice at any rate, and is going to work with us and walk with us through the residential options that many of us may have to confront following hospitalization, or as age catches up with us, perhaps is a good way of saying it. So, Katie, we're thrilled that you would share with it. I've already seen the slideshow, so I know what we're in for, and most grateful.
My pleasure.
So much for you.
Thank you for inviting me.
Thank you for joining us.
All right, so we will get started. So first, just a few words about my hospital, which I'm very proud to be part of. As most of you know, we're located here in Kisco, 233 beds. We're part of a 4-hospital network with Phelps and Lawrence and White Plains Hospital. We also have an affiliation with New York Presbyterian. We are a Plaintree designated hospital and a magnet hospital. We are the only one in the country to have both of those designations, so this is a very special thing for us. We have over 600 physicians on our staff, and our vision is we will provide the highest quality health care within a supportive community setting and state-of-the-art facilities. And if any of you have had the good fortune or bad fortune to come into our hospital, you know it's absolutely beautiful. We provide the highest quality diagnostic and treatment services for our community while assuring access to a coordinated continuum of healthcare services. We seek to improve and protect the health of individuals in the community through programs that promote healing and wellness. Our patients are the community. It's not just the people that come to the hospital. So whether you've ever been there or not, I'm happy to be here to share with you what I know, and I hope you will use me as a resource from this point forward. Another one of our little marketing slides. So who am I and why am I here and why do I have the ability to be able to talk to you about this? I've been graduating from university. I'm currently pursuing my master's degree in case management. I've been a registered nurse for 34 years. My clinical background is in adult medicine and critical care, and I was a previous manager for Oxford Health Plans and managed the boroughs of New York and the state of New Jersey. My current position with the hospital is Director of Regulatory Affairs and Case Management. And I have the distinct pleasure of being Dr. Hal Fetterman's co-chair for our ethics committee. Distinct pleasure. So what are today's objectives? We're going to run through a lot of information. It's very convoluted information. It's very confusing information. Don't expect everybody to walk out of here knowing it, but if it's the first time you're hearing it, at least the next time you hear it, it won't be the first, and there's something to be said for that. We're going to go through what hospital stays, whether you're an inpatient or an outpatient, the discharge planning process from the hospital. We're going to give you an overview of Medicare coverage, all the different parts, your Medicare benefits and how you can access them, your discharge options and what that means, and the importance of long-term planning and some area resources. Okay? So we'll start with what happens when you come to the hospital. So you have the misfortune of being brought into our emergency department. After you've been treated, there's a number of things that can happen. You can be stabilized and you can leave, be discharged from the emergency room. We can put you in what's called observation status, which is a relatively new thing here in New York State. Not nationally, but in New York State, it's a relatively new thing. There was incongruencies between state law and federal law for many years that precluded hospitals in New York State from doing observation. It's been a federal rule for quite some time, and the federal government has begun cracking down on hospitals for not utilizing that properly, penalizing hospitals for not using that properly. So the state, just in February, actually passed laws that enabled us to be able to do this. So it's possible when you come to the hospital, you could be placed in observation status, which means you're going to stay a brief period of time, 24, 48 hours. The other option is you could be admitted to the hospital as an inpatient, in which case you're going to stay at least 24 hours, potentially longer. So your physician is actually the one that makes that determination of what level of care you're going to be placed in. It is solely his or her decision, and they will decide whether you need the services of an inpatient level or whether you can safely be managed in an outpatient level of care. Inpatient means you are admitted to the hospital. Outpatient means you are receiving one or more services of the hospital. And radiology, lab, outpatient surgery, observation falls under the category of outpatient services, but you're not admitted, and that's the difference. As I said, observation means that you are an outpatient. So why does this matter, and what's the difference? In the inpatient arena, your physician needs to write an actual order in your medical record admitting you to the hospital. Everything is driven off that. This will be covered under your Medicare Part A, and you have a one-time co-payment if you're admitted to the hospital and Medicare is your coverage of currently $1,184. Okay? Medicare Part B will cover your physician's charges in that scenario, but unless you have another secondary coverage, Medicare only pays 80% of your hospital bill, so you are going to be liable for 20% of the hospital charges, 20% of the physician charges. As an outpatient, which includes all these different services, the emergency room, observation, radiology, outpatient surgery, lab testing, all the different outpatient things that a hospital can offer, there's no physician order to admit, and those are all going to be covered under your Medicare Part B, and there's a co-payment for each of those, for each service. So if you come to the hospital and you have lab testing and you have radiology services, for each one of those there's going to be a co-payment that you're going to incur. If you're placed in observation, for each service that we deliver to you in that status, there's going to be a co-payment that you're responsible for. This is very important for people to understand because it has potentially big financial implications. We're going to get into that.
Do they go over that with patients at the time?
Yes, we do.
Before anything's done, so we know what's
We
going
do.
on?
I think we can do better at it. We're actually evaluating how we're doing that now. We started doing observation at Northern Westchester about a year and a half ago, and we started with one diagnosis only, because that's the one that the federal government was targeting our hospital for, and that was chest pain. So we started our process about a year and a half ago. We have now opened it up to every possible scenario that somebody could walk through the door with. So we're trying to perfect our communication process. We think we're explaining it well, but that's part of the problem. Because we think we're explaining it well, but it doesn't necessarily mean you're understanding what we're saying.
I was just checking on the copay, but I will know what our financial obligation is at the time before.
It's actually, that we can't predict for you because we don't know what your doctor's going to order over the course of your time with us.
Oh,
Right. That's part of the issue. We know you're going to have one, but...
and there's no cap?
Nope.
Okay.
So according to Medicare, CMS, which is the Center for Medicare and Medicaid, this is their definition of what an inpatient is. A person who has been admitted to a hospital for bed occupancy for the purpose of receiving inpatient hospital services. Generally, a patient is considered inpatient if formally admitted as an inpatient with the expectation that he or she will remain at least overnight and occupy a bed, even though later it develops that the patient can be discharged or transferred to another hospital and not actually use the bed overnight. That's clear, right? So this is Medicare's definition of what an outpatient is. A person who has not been admitted to the hospital as an inpatient, but is registered on the hospital's records as an outpatient and receives services rather than just supplies alone from the hospital. It's fairly nebulous as well. And this is their definition of observation care. A well-defined set of specific appropriate services, which include ongoing short-term treatment assessment, reassessment, before a decision can be made regarding whether patients will require further treatment as hospital inpatients, or if they are able to be discharged from the hospital. Observation services are commonly ordered for patients who present to the emergency department and then require a significant period of treatment or monitoring in order to make a decision concerning their admission or discharge. Okay, observation is outpatient. This is used for your physician. If they're not sure what's wrong when you come in and they're treating your symptoms and they're doing further diagnostic testing, trying to determine what the problem is, it's quite likely you're going to be placed in observation. Once they've determined what the problem is, if that problem warrants continued treatment in the hospital, you will be admitted. If it doesn't, you will conclude your treatment and you will leave in an outpatient status. This makes a difference when we get further on in the presentation in terms of being able to access benefits, because some of the benefits you'll want to access post-hospital are dependent upon your length of stay in the hospital as an inpatient. So you could spend 2 days in a hospital in observation. Then on the third day, you get admitted, but the clock only starts ticking on that day for your inpatient qualifying stay to be able to access other benefits. Okay, so we'll go into that further. All right. Your status in the hospital dictates what benefits you can access when you leave. Your financial liability for the hospital and those services varies depending on what your status is. And the length of time in the hospital can vary depending on what your status is. All right? You don't get any different care. When you come to the hospital, it's not going to feel any different to you. At Northern Westchester, what we do if you're placed in observation status is you go upstairs to one of our floors, you're put in a room, in a bed, all the same nurses are taking care of you, your doctor is there to take care of you, feels absolutely no different. That's a good thing, but it makes it very difficult for people to understand that they're in a different status. So that communication up front is very important. But my advice to you would be make sure you ask. If you need to stay in the hospital and you're not going to leave immediately and go home, make sure you ask and you clarify. Yes?
But do you as a patient have any control over how you're admitted?
You don't.
So you're asking for informational purposes, but
Right.
you can't.
Right, right. You have the right to refuse. You know, I mean, if you...
While you're having chest pain?
Yeah, you know, I mean, you have that right. Unfortunately, right now, patients don't have any right to appeal their status. It is solely your physician's decision. So if you don't agree with your physician that you should be in observation, right now there's no process for you to follow to appeal that. However, Medicare is supposedly looking into that because there's something wrong about that. There's something wrong about this. There's a huge impact on people. And every other aspect of Medicare affords you some kind of appeal right to have your case reviewed by an external organization or external agency. This does not currently. So I think that will change in the future. Yes?
How does your doctor make that decision between in and out?
Your doctor makes that decision between in and out based on his thought process. And which is somewhat subjective. He uses objective information based on your lab test, your radiology test, your clinical condition, but he makes that decision based on whether he feels he can, the likelihood of being able to treat you and get you out of the hospital in a short period of time, or whether he thinks you're going to need to remain for a longer period of time. And then also the intensity of the services he feels you're going to require. So if you're going to need some monitoring, some medications, and you're likely going to go home in a day or two, chances are he's going to decide to place you in observation. But if you're going to need antibiotics for 5 days, you may even need surgery, you need invasive testing, chances are he's going to place you into an inpatient status. Okay? Yes?
If you refused the observation status, you could just go home, right? I mean, then the kind of forces the doctor's hand, it would think.
Right, it does. It does. But what would happen in that circumstance, usually, the doctor's recommending to you that you stay.
Right.
Okay.
And then you say, I don't want to be on observation status.
Right. That is your choice.
Yeah.
But then you would not be discharged. They would probably have you sign out against medical advice. If you say you don't want to be on observation, it doesn't mean the doctor's only other option is to place you on an inpatient.
Well, yeah, he says, oh, sure, it's your own risk.
Right, exactly.
In a way, it's his risk too, because here's this person, he's supposed to care for him.
Right. Right. Our doctors really struggle with this, I'm going to be honest with you. They don't think in these terms. The people that wrote the Medicare rules are not doctors. They're congressmen, they're senators. They're not doctors for the most part. So these rules do not interpret well to a physician. A physician treats a patient based on their medical education, based on the likelihood of harm coming to that patient.
Right.
And that's what they judge their decisions on, and that's what they judge their treatments on. Okay? They do have total control over what happens in terms of whether you get admitted or not, and they are the only ones that do. There is not another entity. A nurse cannot admit a patient to a hospital, physical therapist, an administrator, nobody. The only person that can admit a patient to a hospital is a physician. All right?
Yes. Now, the physician, is that your physician? Is that the hospital's physician?
Well, in this day and age, that's a good question.
I mean, if you want your own doctor, if you come in and you want your own doctor.
In this day and age, what most hospitals have done is they've employed hospitalists. So all of you probably have your own community physician. Maybe some of you have doctors at Mount Kisco Medical Group, maybe other physicians in the community. Mount Kisco Medical Group has their own hospitalists. The hospital itself has employed its own hospitalists. So when you come to the hospital, it's likely that you will be cared for by a physician that you may never have met before. But they work with your doctor. Your doctor has chosen to use that program, okay, to take care of patients that are hospitalized. The good thing about these doctors is that all they do is hospital medicine. They are truly experts at hospital medicine. They are there around the clock, should you need them, which your community doctor won't be. They will pay you a visit, and they go back to their office. They're not there in the hospital all the time. These hospitalists are there around the clock. But you don't have the same kind of relationship with them. They do talk to your doctor. Depending who your doctor is, your own doctor may come and visit you while you're in the hospital. And you can always call your doctor. There's certainly nothing that precludes you from doing that. But most hospitals nowadays have hospitalists because they've been shown to be much more efficient. They're there around the clock, which is invaluable. And unfortunately, that's the way of the world. But it doesn't always feel right to patients when, you know, you need your doctor the most is when you're in the hospital and now he's not there for you. That's the way a lot of people perceive it.
So who employs them, the hospital or the medical group?
Well, at Northern Westchester Hospital, it's both. Now, Kisco Medical Group employs a group of their own hospitalists that care for patients that belong to any doctor in the Mount Kisco Medical Group. So that's roughly, I would say, 35–40% of the hospital's population. The rest of the population is cared for by hospitalists that the hospital has employed. So for all the other doctors in the community, doctors from Westchester Health Organization, they take care of the rest of those patients. There's a handful, and I can count on one hand, of the internal medicine docs that still admit their own patients. It's really kind of a thing of the past, unfortunately. But that's the way the world is going. Confused yet? I guarantee you probably will be. So hang in there. So now we're going to jump on to discharge process and what your options might be. So the truth about hospital discharge. It begins when you arrive at the hospital. I can't stress this enough. A lot of people feel like we're booting you out of the hospital when we talk to you about leaving as you're just getting settled into your bed. But it's a very important thing. First of all, none of you come to the hospital expecting to stay for the rest of your lives, usually. Your goal usually is to get out of the hospital, and sometimes it takes a lot of work and a lot of planning to coordinate the plan that you're going to need. So we start as early as we possibly can. We don't want to make people feel like you're not welcome to stay. That's not the point behind it. But we need as much time as we can to put the best plan together for you when you're going to leave. It's a very complex process. It's truly a very complex process. And our healthcare system is really not so good at moving people from one location to another. This is something that's been identified in all the literature. It's been talked about by Medicare. It's something we have to get better at. So we really try to get involved as early as possible to improve the plans we're putting together, to involve the other providers that you're going to need when you leave, to get them involved sooner. So by the time we're handing you off to someone else, they know you almost as well as we do. Okay? It's not meant to make you feel unwelcome in the least. It's to really try to make sure we're on top of what you're going to need when you leave. Okay? Some statistics for you. According to the Mayo Clinic, 42% of people discharged know their diagnosis. Only 42%. And only 37% know what their medications are for. That's really scary. That's really a scary thing. Medicare estimates that there's over $17 billion that have been spent in hospital readmissions. Readmissions are really failures, okay? For the most part, some people have definitely chronic diseases that they just continue to decline, but there's a lot of readmissions that should not occur because people don't know their diagnosis and they don't know how to take their medication. Those are the two biggest factors that have been shown to contribute to hospital readmissions. So our job is to get better at educating people while they're in the hospital, to make sure you know your medications when you leave the hospital, that you can get your medications, you can afford them, or we know that you can't and we make other arrangements for you in terms of that. We really have to get better at this. So this is our charge, but it's your charge too, because you want to make sure that you know when you leave the hospital, you are well informed and you feel capable of managing yourself or your loved one. Okay? One of the things the hospitals we're actually putting in place starting April 1st, we're going to have what's called a transitional care coach, which is a program with a registered nurse who's going to follow certain patients that are deemed at higher risk out into the community to help them with exactly this. They're not home care nurses, they're not therapists, they don't provide hands-on care, but they're going to help people understand. They're going to continue the teaching that's begun in the hospital. They're going to help you navigate the healthcare system to make sure you get to your doctor in 3 to 5 days after discharge. Has anybody ever had the opportunity to try to call your doctor and you're told the first appointment you can get is 3 weeks from now? All right, when you discharge from the hospital, the scientific evidence supports the fact that you should be seen by your physician within 3 to 5 days. Okay? You get out of the hospital and you call to make that appointment and they tell you you can't have one for 3 weeks. You say, all right, if that's the first one you got, I'll take it. And in that 3-week period, there's a lot can go wrong and you end up back in the hospital. So the hospital's trying to make those appointments for you with your doctor before you leave. And this transitional care coach will make sure that you got that appointment, will help you navigate that doctor's office to get the appointment if you don't, and give you those empowerment skills to try to work in this system and advocate for yourselves. Okay, one of the biggest obstacles we face is patients and families not understanding how to do all this. Okay, that's no surprise. My little prop here, this book, this 6-inch binder, that's the Medicare rules. Part of them for hospitals and discharge. Part of them. And that's not even Obamacare. Okay? So, I have that book in my office. I refer to it all the time because I don't have all that memorized either. All right? So how does the general public know all that? You can't. There's no way that you can. And in terms of your discharge plan, unless you needed to use the services of a post-acute provider, a home care agency, a nursing home, an assisted living, chances are you're not familiar with them. So all of a sudden something happens, you're in the hospital, we're saying you need to go for some short-term rehab, where do you want to go? And you have no clue. You're not in the physical condition to be able to go out and look around. And I'm not allowed to recommend anything to you. That's another regulation I have to live by. I can't tell you this nursing home is better than that one. Okay, I have to give you a list, which is actually in your packet. You have the list that we hand out. It's every facility in the county. But I can't tell you one is better than the other.
But your pastor can.
There you go.
There you go. Your pastor can.
There you go.
Okay.
There you go. And there are times, I'll be very honest with you. I mean, I'm the director of my department, so I don't usually deal directly with the patients and their families. I get involved in certain cases. My staff is precluded from giving you those recommendations. But if you or a loved one come to the hospital and you're really struggling with this, my contact information is in your folder. You can stop by my office. I'll have any off-the-record conversation with you that you need me to have with you, okay? Officially, I can't make one recommendation to you over another, but I've been through this. I did this with my own mother last summer before she passed away. I've been in those shoes. I know what this is like. It's extremely difficult, and it's very confusing, even when you're in the business, but it's also heart-wrenching. So you don't necessarily think as clearly as you want to, but some of this is really important and it makes a big difference. So call me anytime, drop in, let me know if I can help you. So options. Okay, you land in the hospital, what are your possible options? Well, in terms of short-term options, you could go for what's called acute rehabilitation. What that is someplace like Burke Rehab in White Plains, or Phelps Rehab Unit, okay, Helen Hayes over across the bridge. Those are acute rehabs. Skilled nursing facilities. There's, in this area, there's Somers Manor, there's Waterview Hills, there's a number of them all over the county. Skilled home care. The VNA of Hudson Valley, the VNS of Westchester, VNS of New York. There's many, many, many home care companies. With Medicare and home care, in order for Medicare to pay for home care, you have to make sure that whatever home care agency you're using is Medicare certified. Okay, there's lots of home care agencies out there that are licensed by the state of New York, but they're not Medicare certified. So you want to make sure that you choose a home care agency that's Medicare certified in order for them to pay for your services. This is some of the stuff that my staff will help you navigate through if you end up in the hospital. The other option is, as Dr. Fetterman and Victoria talked about last week, is hospice. And there's two levels of care in hospice. You can be an inpatient hospice or outpatient. Inpatient hospice is short-term for the most part. It's usually utilized in the last 2 weeks or so of life, or for symptom management, and then the individual will return back home. So the inpatient status for hospice is pretty short-term. Then there's other long-term options other than just going home, which some people can just go home from the hospital too. But there's the residential facilities, which includes things like your assisted livings, your independent living facilities. Okay? Nursing homes where people reside in the nursing home. That's called custodial care, and they now reside. So they give up their house in the community, they're now in the nursing home on a full-time basis with no intention of leaving. Okay? There's custodial home care, where you don't have any of the skilled needs that Medicare says you're going to have. You want to stay in your own home. A lot of people with Alzheimer's may have this kind of care, where they have a living caretaker with them round the clock. Maybe they live with family. Some people, even with that home care, they may go out to an adult daycare program during the day for socialization. All right, and there's several of those in our areas. And in your packet are lists of all of these resources. And the adult daycare programs work very well, especially for families that are trying to take care of a loved one, and you have to work. So you have your mom living with you, but you still have to keep your job. So mom goes to adult daycare during the day, where they make sure she gets her meals. There's medical model and social model adult daycare programs. So if your mom has the need for wound care, or she's a diabetic and needs insulin throughout the day, some of the programs are able to provide that, the medical model programs. The social programs are more what they sound like, more socialization. So they go, they eat, some of them will do some personal care if they need help showering, things like that. And then at the end of the day, mom comes home when you get home from work. Okay? A lot of these operate 5 days a week. There's a couple that operate 6 days a week. I'm not aware of any that are currently operating 7 days a week. Okay? A lot of them will provide transportation. They'll pick mom up. They'll bring her home again, so you don't have to burden yourself with that as well. So it's an option for people. And then there's hospice at home, which again Dr. Fetterman spoke about last week. Usually, that can go on for several months. Unfortunately, not enough people utilize hospice early enough on in their course of illness to really benefit from it. So we'll go through each scenario and what the discharge option is going to be. So if you come to the hospital, you're in the emergency room and we're going to discharge you. Any of those things we just talked about are still options for you. Okay? So if you come to the emergency room and we're going to send you home, If you wanted to go to a nursing home, we can make that happen for you. The issue is how it's going to be paid for, because it's all driven by what happens to you when you get to the hospital and what status you're in. If you're put in observation status, again, it's intended for short stays, to determine the need for inpatient hospitalization, to provide short-term treatment, and we anticipate a discharge within 24 to 48 hours. All these same things apply. You can opt for any one of those discharge plans that you would like or that you need, but it does not meet the Medicare criteria to be admitted to a skilled nursing facility. Okay? That's very important. This is where I'm seeing a lot of patients and families struggle since we started doing observation. A lot of people, and even the physicians, say to families who are trying to manage their elderly loved one at home, take them to the hospital, they'll help you get them in a nursing home. And that's the way it used to be. People would come to the hospital, we put them in a bed, we take care of them. Medicare requires you stay in the hospital 3 days in order for Medicare to cover your stay in the nursing home. We put you in observation, that doesn't apply. Okay, again, that's right. It's really important to know what status you're being placed in. You come in and you are admitted to the hospital. Well, all those same options apply. Okay? No matter what status you're in, any discharge plan is possible. What's different is whether you can access your Medicare benefits to pay for it. That's what makes the difference. Okay? So it's really important to know. All right. Any questions at this point? All right. Here we go. On to the next part. So, the discharge planning process. What do we do on our side? Okay, just so you understand what we go through. First, we identify patients that are in need of discharge planning. Not every patient that comes to the hospital needs discharge planning. Some people come in for surgery, they're well, they have good family support, they have their surgery, they recover, they're going to go home, they're going to be fine. They don't need discharge planning. Moms and babies, when you come in to have your baby, chances are you don't need discharge planning. You're going to have your baby, you're going to be scared to death, you're going to take your baby home, you're going to be scared to death, but you're going to cope and you're going to learn the same way the rest of us do. Okay? That lower risk population of people don't really need discharge planning, so a lot of this doesn't apply to them. So what my staff does is we try to identify early on those people who are going to need our services. There's some risk factors we look at, but they're not the be-all and end-all. We look at people's age. We look at whether they've had readmissions. We look at the number of medications they're taking. We look at what their social situation is. We look at whether they've had any mental status changes, whether they're functionally debilitated. Okay? Those are the kind of things we look at to try to target patients who could benefit from our services. Then we assess and identify what their problems are. We do that collaboratively in a team between the nursing staff and the physician. We develop an initial plan based on the clinical need, and then we discuss it with the physician. The physician, again, really is the head honcho here. He or she kind of controls everything. There's nothing we do, there's nothing a nurse in a hospital does that the doctor is uninformed about. All right, he calls the shots. After we do that, after we've looked at your circumstance, after we've figured out what you're going to need from a clinical perspective, after we've spoken to the doctor to make sure we're all on the same page, then we're going to go look at what resources you have. Because what we're charged with is making a safe plan for you based on what your clinical need is. That's job one in the hospital. So that's what we're going to do first. So we're going to go for the Cadillac of discharge plans based on your clinical need. Then the next step is to identify what resources you have to implement those. This is where it sometimes gets sticky. All right? Try to determine whether medical necessity exists to access the appropriate benefits. Medical necessity is a very important term, and I'm going to go into that in another slide or so. And then the last step is you're not discharged from the hospital until your doctor says you are. Okay? There's no hospital administrator that can discharge you from a hospital. There's no nurse that can discharge you from a hospital. It's your doctor. When your doctor says you're ready to go, you're ready to go. And if your doctor says you're ready to go and you don't think you're ready to go, You do have appeal rights in that circumstance. And you can object if you don't feel ready, if you don't feel prepared, you can appeal. Okay? So in terms of going through that process, who's responsible for that? So as I started to say, with your doctor, with the patient, the doctor, the caregiver, whoever that may be, and anyone else you might want involved in that scenario, we're going to put this all together and make a plan for you. At Northern Westchester Hospital, my department is comprised of nurse case managers. They're all RNs. Each one of them individually has over 30 years experience in nursing. So we're, kind of the grandmothers of the hospital. But they have a lot of clinical experience, and in our particular hospital, they're all nurses. I have case managers that are on all the inpatient units, so all the med-surg units, the ICU. We don't have case managers in maternity because they're not really needed there. But we have a case manager in the emergency department. So even if you came into the emergency department, God forbid you had an ankle fracture, but you didn't need to stay. But now you need some equipment in your home because you need a wheelchair, you need a cane, you need whatever. That case manager in the emergency department is going to be able to get that for you, arrange for that so you can safely go home. Okay? Other facilities, other hospitals may do this differently. In some hospitals, they have social workers. That's historically who did discharge planning in hospitals. And in some other hospitals, they may have a combination of the two. Some places pair up a nurse and a social worker to work on cases. So it may just be a little different from place to place. But in Northern Westchester, we have nurses. So now we're going to go through, to the extent possible, pretty much what's in that book. All right, so in terms of your Medicare coverage, your Part A is considered your hospital insurance or your inpatient insurance, okay? This is an entitlement benefit that's available to people who have worked and paid in Social Security long enough, okay? You have to have worked so many quarters throughout the course of your life to be eligible. Those that haven't can purchase it if you're a United States citizen. It's currently about $500 a month to purchase Medicare if you're not otherwise qualified for it. Available for the primary, usually to people 65 years of age and older. It is also available to younger people with certain disabilities who are on Social Security disability for 24 months. So you could have a 25-year-old who has a traumatic brain injury who ends up having Medicare coverage because they've now been disabled, unable to work for 24 months or longer. Okay. A lot of our disabled young adults have Medicare because they have been determined to be disabled. They collect Social Security disability for that, so they may have Medicare, whether they're 20s, 30s, 40s. The other entity that receives Medicare are people with end-stage renal disease. Because when you have end-stage renal disease, it's a critical, potentially deadly illness. You must have dialysis. And if you don't have a payer source for dialysis, you will die. So Medicare covers those people almost immediately so that they can get dialysis. Now that said, should you be fortunate enough to receive a kidney transplant, so now you no longer need dialysis, your Medicare coverage will terminate. So they'll cover you during the period of time when you're diagnosed with end-stage renal disease, when you need dialysis to survive, but if you're fortunate enough to get a transplant, it terminates. Medicare Part A covers inpatient care in hospitals, inpatient care in skilled nursing facilities. It covers hospice care and home health care following an inpatient hospitalization. So if you're in the hospital as an inpatient and you go home and you have home care, those home care visits initially are going to be paid for out of your Part A benefit because it's linked to a hospitalization. Okay? When you go to a nursing home, it's going to be paid for by Medicare if you have a skilled need because it's linked to the inpatient hospitalization. Okay? There are a finite number of hospital days available to you, though. A lot of people think that, Medicare just pays, it's endless. Any of our insurance, no matter what it is, they just pay for what you need. It's not the way it works. For Medicare, you have a total of 150 days each time you get ill. Okay? Days 1 through 60, your acute care days, you're able to access and utilize for the one-time deductible we talked about earlier. Currently, that's $1,184 in 2013. That changes annually, that amount. So every January, that amount might increase. I suppose it could decrease, but I've never seen it decrease. So it always seems to go up. Last year it was $1,140, now it's $1,184. If you stay in the hospital for those 60 days, and now you're going to be there longer, between days 61 to 90, you have a daily copay of $296. If you have a secondary insurance, your secondary insurance will help cover the cost of this. But if you don't, you have an almost $300 a day copay for your continued stay in the hospital if you're there more than 2 months. Beyond that, if you were fortunate enough to leave the hospital, okay, this 90 days, this bucket of days here, will renew. But in order for that to renew, you have to remain out of the hospital, out of a nursing home, for 60 consecutive days. Okay? Now, I don't know about you, but if I was sick enough to be in the hospital for 90 days, it's going to be really hard for me to stay home for 60 days without some help. Okay? But that's what you have to do to get that 90 days to regenerate. Then, in addition to those 90 days, you have 60 lifetime reserve days. This is intended for catastrophic circumstances. They're used only after you've exhausted these 90 days, but you still need to remain in the hospital. You have this other bucket of 60 lifetime reserve days. Once you use those days, they're gone. They do not renew. But once you use those days, there's a $592 a day copayment, which is pretty hefty.
Is this like on an annual basis?
These 60 days are per lifetime.
Okay. But the first part of it.
The first 90 days are for spell of illness.
Okay.
But you remain in this 90-day benefit period unless you are out of the hospital for 60 days, 60 consecutive days. So let's say you came to the hospital, you were there for 30 days, you go home. 30 days later, you come back. You're still using up this first bucket of days. You haven't renewed yet to have your full 90 days back.
Does it matter which, that you have a different illness?
No, it does not.
Does it matter?
Does not, unfortunately. And it's not really optional whether you're going to use these days or not.
What does the 150 refer to?
60 plus 30 plus 60. That's what the total 150. So if you had a catastrophic situation, Medicare would cover you for a total of 150 consecutive days.
But the 90 are renewable, but
The 60 lifetime reserve days are not.
so you only have 150 once, and after that you have 90.
Right. Now, in order to use your lifetime reserve days, the hospital needs to have you, A, be informed, to consent to using them. You can refuse, okay? But if you had a secondary insurer, likely your secondary insurer is going to mandate that you use them, or they're not going to pay. That's how it works. Get you coming and going. Yes?
How much does a hospital stay one night cost?
It depends on what services you're receiving. If you're in the ICU, it's more costly than if you're on a
let's say
unit.
you're in bed.
Roughly, ballpark figure we use today is about $1,500 a day.
Wow.
That's for your bed, your 3 meals, and your basic nursing services.
Can you bring in your own food and say
Our food is really pretty good. Okay? So you have to really be aware of this, and you have to be, somewhat savvy when you come to the hospital, because it's not a free ride. And a lot of times people will be hesitant to leave, or they don't want to take mom home, or they're not ready. But remember, you're using up these precious days. Okay? So people like me in the hospital want to be really good stewards of your benefit. I don't want to waste your time in the hospital. You might need it. Okay? So I want to try to get you out of the hospital as expediently as I can, safely, but I don't want to waste your benefit because it's costing you money and you may not get it back. and you may need it again, okay? Yes.
After a certain age, do you recommend, if it's possible, to have 2 different insurances? Because you said...
I think it's always a good idea if you can. You know, some people are fortunate enough to have a secondary insurance as a retiree benefit, okay, which is wonderful. Others are not. So if all you have is Medicare, you're going to have a lot of out-of-pocket expenses. So depending on your circumstance, I mean, if you were to, I've never actually sat and sort of done the cost-benefit analysis, but probably if you were to have to, even in a year, lay out these co-pays I'm talking about, it probably would be in excess of what a premium would be to buy a secondary plan. Would be my guess. Even through AARP or any of the other Medigap policies. And even with that, none of them are going to pay 100%. So your Medicare pays 80%. Whatever secondary you have pays 80% of the remaining 20%. So there's still 20% that you're still going to be responsible for. So no matter which way you go, there's still going to be out-of-pocket expenses. So I should just also mention here, and I didn't think to put it in the slide, at least for Northern Westchester Hospital, and all hospitals really have to have this policy. We're not going to deny anybody care who can't afford to pay for it. That's not something we do. That's not something hospitals are allowed to do. But it's certainly not something Northern Westchester does. We have charity care policies. We can screen people based on their income, and they can be eligible for anywhere from 0 to 100% charity. And once you've gone through that screening lasts for a period of 5 years. We don't ask again. And you can come for services, and that charity care is applied to any balance you might ever owe to the hospital. Don't hesitate to ask about that if you needed it. Okay? A lot of these elderly people, they're writing their little checks every month trying to pay off their bills. I know my mother was. And it's, you know, she was deciding whether to buy her groceries, her medications, or pay the hospital bill. You don't need to do that. There's ways around that. Okay? And we're there to help. So ask questions. Don't be afraid. Don't be intimidated if you don't know. Just ask.
And that's possible because we support the hospital in our annual gifts?
No. We do that for anybody, and we do that for people that are not even from our community. We've seen a lot of people in our hospital now that are not from this community. They come. Our surgeons are bringing people from quite a distance away. Orange County, the boroughs of New York, because we have some pretty state-of-the-art stuff going on down the street. So people are coming from all over, and if they can't afford to pay, these policies apply to them just like everybody else. Hospitals will never turn anybody away. Okay?
Questions?
Yes.
That screening, I mean, that happens, can you get pre-screened so that you're all set to go?
For the charity? If you know that you're going to need to access the services at a hospital and you're concerned about what your co-payments may be, yes. So your doctor says you need to have surgery, and maybe you only have Medicare to cover it. If you're concerned about how you're going to pay that other 20%, yes, they will screen you ahead of time. There's, you know, documents that financial documents that our patient accounts department would ask you for. But once that's done, that holds true for a 5-year period of time. Okay? So now we'll move on, still under Medicare Part A, to skilled nursing facility benefits. Okay? So there's a finite number of days Medicare will pay for you to be in a skilled nursing facility as well. In total, you could have 100 days in a skilled nursing facility. No more. Days 1 through 20, they pay in full. Days 21 through 100, you have a daily co-payment again of roughly $150 a day. And that amount changes annually too. Medicare is only going to cover your stay in a skilled nursing facility unit if you have a skilled need. And you've had that 3-day qualifying stay immediately prior to your stay in a skilled nursing facility. CMS definition of skilled care is when you need skilled nursing or rehab staff to treat, manage, observe, and evaluate your care. That's when you can access your skilled nursing facility benefits. So you need to be able to say that you require the services of a nurse or a therapist on a daily basis. When you go to a skilled nursing facility, you don't need to have to see a physician every day. If you need to see a physician every day, you belong in a hospital. Okay, that's another criteria Medicare uses for hospital. The physician must see you every single day. Okay, the physician has to document in your medical record every single day. All right? In a skilled nursing facility, that's not the case. It's kind of based on what their regulations are. The doctor doesn't have to see you more than once a month in a skilled nursing facility by regulation. A lot of the skilled nursing facilities require, at least on their short-term units, that physicians see their patients at least every 7 days, but that can vary facility to facility. All right, so the kind of things that you would go to a skilled nursing facility for after a hospitalization was if you continue to need injections, if you continue to need intravenous medications, wound care that can't be done at home, physical, occupational, or speech therapy. Okay? And again, days 1 through 20 are paid in full, and thereafter, they're paid with a daily co-payment. And one of the things you want to be careful of, and I'm not suggesting that any of the facilities around here do this, but what we've seen sometimes is that nursing homes will take you or your loved one, and they keep you for 20 days. Okay? And then all of a sudden, they're saying, even though you're no different today than you were yesterday, you're ready to leave. All right? Just be careful about that. All right? No going in. Some places will even ask you to sign a financial agreement up front to make sure they're going to get their money. Most of the skilled nursing facilities around here who provide excellent care, but in this county, most of them are privately owned, or they're corporately owned. All right? They're not nonprofit. A couple are, most of them are not. So their mission and their vision is a little bit different than what the hospital might be. All right? So just keep your eyes open and ask questions going in.
How does the day program work when you're an outpatient?
In a nursing home?
Or like for rehab?
That comes out of your outpatient benefits. That's your Part B of Medicare.
Oh, that's not A, okay.
Right. We're going to get to that in a minute.
Thank you.
Okay? Matter of fact, right now.
When you have skilled nursing at home, is that covered by Medicare?
From a home care agency?
Yeah.
Yes, it is. So you could have nurses from the VNA of Hudson Valley come out and visit you at home. The difference is they don't come every day. It's intermittent, which is 2-3 times a week. Same with the physical therapist. It's 2-3 times a week. A lot of people are under the impression that when you're going to have home care, the nurse is just going to be there with you. That's not the case. That's not the case. They visit you 2 or 3 times a week. You may...
Would your secondary insurance pick up the other days, the off days?
No. No.
So you have to stay at a nursing home.
If you need that intensive level of care where you need a nurse around the clock every single day, you really don't have any other... You could privately hire your own nurse. That'd be okay. But that would, financially not be feasible for most. So moving on to Part B. Any other Part A questions before we move on? So Medicare Part B is available to purchase if you are granted Part A through the entitlement. Okay? It's provided to those with end-stage renal disease who are given Part A. So those people with kidney disease who are given Part A, they also get Part B. It covers medically necessary services from doctors, healthcare providers, outpatient care settings, home health, durable medical equipment, and some preventive services. So this will help pay for your visits to the doctor. It pays for your outpatient physical therapy or occupational therapy. It pays for some of your home care if you weren't in a hospital prior. So if you go to your doctor and your doctor says you have, you developed a wound on your leg. So he wants to send the visiting nurse in to see you to do the dressing changes every other day. In this scenario, because you weren't in the hospital first, this will come out of your Part B. Okay? So again, like I said earlier, when you're in the hospital, that drives how everything else is paid from that point forward. Okay? When you're not in the hospital first, some things are not going to be covered or they're going to come out of your Part B. Pays about 80% of the covered services after you've met your deductible if you use providers who accept assignment. So there actually are some physicians in our area, I don't think too many anymore, that don't accept Medicare. So when you go visit that particular physician, you're going to have to pay them up front whenever they choose to charge you and then you'll have to submit the bill to Medicare and get back 80%. Not necessarily of what you paid, but 80% of what Medicare thinks is reasonable and customary. Then on to Part C. What Part C is Medicare Advantage. These are the Medicare plans that are administered by companies like Blue Cross, United, Aetna. There's a whole bunch of them now that offer Medicare plans. They include all the benefits for the regular fee-for-service Medicare, Part A and Part B. They usually include Part D, which is your prescription drug coverage. They must offer at least what Medicare offers, but they can do more. The thought process in a managed care agency is that they focus a lot more on preventative services because they believe that that's where their dollars are best spent because they'll pay more up front and less on the back end. It's true to some degree, I suppose. Medicare does not, straight Medicare does not necessarily feel that way. They're going to pay for things as you need them. They don't pay for a whole lot of preventive stuff, so it's a slightly different thought process. But what you need to be careful about with this is that it usually limits your access to providers. Managed care companies usually have a finite network of providers. You can't go outside that network or they're not going to pay. Or if you have out of network benefits, they're only going to pay a lower portion if you use somebody out of network. So you want to be very careful because this really limits, when you finally, I've seen this happen to families a lot. Mom or dad or whoever, got this invitation to go to the diner and, Aetna signed them up for Medicare one morning for a free breakfast. And then all of a sudden they have, something that goes wrong and they come to the hospital. Your hospitalization will be paid. But it's what happens next. If you want to go to the same nursing home where dad was or the one that's next door to your house, they may not be in network. And you can't. And it causes a lot of hardship and it's very difficult for people to understand in their crisis situation in the midst of everything else. So if you go with a managed care Medicare plan, know what the network is so that the providers you may ever need, you're comfortable with are in your network. That would be my best advice. Yes?
That's also true of doctors.
Yes, doctors also.
You may not be able to go to your doctor.
Correct. So if you have, your doctor, your cardiologist, your pulmonologist that you would never go to anybody else, make sure they're in your network. Otherwise, you're going to be in trouble. You're not going to be able to go to them, or you're going to have to pay full fare. Medicare Part D is also administered by Medicare, and this is your prescription drug coverage. Okay? This is still very confusing for people. It covers a certain amount, up to a certain dollar amount, then it covers nothing, and then it picks up and covers again. There are many Part D plans out there. I think at last count there was over 60 in the state of New York. You really need to examine these plans with your list of medications because each plan has different medications on their formulary. So you want to make sure that whatever drugs you're taking are going to be covered under your Part D plan. Okay? It's another attraction to the managed care plans because you don't have to worry about that. It's not a separate thing. They just cover everything all together. But just be careful. So, any other questions? Yes?
I have long-term care insurance. Where does that come in?
Good for you. Good for you. Long-term care insurance gets you nothing for the hospital. It may or may not get you something for the nursing home if you choose to live in the nursing home. It will likely cover or reimburse you for part of the cost of an assisted living facility or custodial home care. But it's oftentimes very difficult to access. What I'm seeing, because long-term care insurance is a relatively new thing, there's not a lot of people that have it. But the plans are very unregulated. They don't have to adhere to the Medicare rules, and they don't have to adhere to the managed care law or any of that. So they kind of can craft their own policies. I've seen people who have long-term care insurance who you're not able to access it until you're in need for over 4 months. Other plans are written where they'll pay you a daily rate and you just have to submit your bills to show that you had the services. So if you have a home health aide that you choose to have, come into your home and help you, you pay the home health aide and then you get reimbursed by your long-term care insurance. It can be a wonderful thing. The premiums, I think, are a little costly and a lot of people can't afford them, especially the older population living on fixed incomes. It's really a cost that they can't incur. I'm hoping over time that long-term care insurance will be something that will become a retiree benefit. I know at the hospital they actually offer it as a benefit option now. We can buy it at our ages, and you know, whether it's worth it to pay into it for all those years before you need it, that's a personal decision. But it's becoming more available. It will help you, but just make sure you understand the terms of your policy, how to access the benefits in your policy, and make sure you appoint somebody to be able to do that on your behalf if you can. Because usually when you need to access it, it's your wife, it's your child, it's whoever who's trying to utilize that policy to arrange a discharge plan for you. So you need to give somebody else the right to talk to that company, otherwise it becomes a problem. We've had that issue too, where we can't find out any information because the person that owns the policy is unable to make that call. It becomes an issue. Yes?
I understand also there are some facilities like assisted living or skilled nursing that will not accept those payments.
Right, they don't, most facilities don't accept payment directly from the long-term care insurance. It works like old insurance used to, where you got a bill and you submitted it and you know, you had to pay your doctor directly and then get reimbursed from your insurance company. More like indemnity plans. That's the way the long-term care insurance works. Okay? All right. So one of the biggest things that you need to understand about being able to access your benefits is just because you have benefits to cover certain things doesn't mean you get to use them when you want to. You only get to use them when you need to. And this is true of any insurance, Medicare, managed care, Medicaid, any of them. The key term is medical necessity. All right? Medical necessity is defined as activities which may be justified as reasonable, necessary, and or appropriate based on evidence-based clinical standards of care. The services must be determined reasonable and necessary based on Medicare's policies. That book. Okay. That book. That's Medicare's policy. It's just
how many
reasonable
want
and
a
necessary.
It's online.
And this is a really important thing, and that's one of the things that we try to do in the hospitals. We work with the doctors, and all we're trying to always make sure that there's medical necessity to everything that gets done. All right. Number one, that's how we're going to be able to access benefits for you and arrange plans for you, is to demonstrate that there's medical necessity. The other thing the hospital's charged with doing is anything we bill Medicare for has to be medically necessary, otherwise it's fraudulent billing. So we spend our lives trying to develop and identify medical necessity. All right? It's not your job, but you need to understand that that exists. Otherwise, you're not able to access your benefits. So a perfect example, and this has happened, is patient comes to the hospital, elderly person, they're admitted in the hospital as an inpatient because they failure to thrive at home, family can't take care of them. They're really not meeting the criteria for a hospital stay, but they've been admitted. Family wants them to go to a nursing home, so hospital sends them to the nursing home. Hospital bills Medicare, nursing home bills Medicare. Medicare takes a look at the individual's hospitalization and says, you know what, this person didn't need to be in the hospital. Medicare takes the money back from the hospital, they don't pay them for those days in the hospital. Hospital can't bill the patient, so you don't have to worry about that. The hospital loses. The nursing home bill gets rejected. The nursing home bills the patient, and they can. All right, so this is why this is important.
Why does the nursing home get rejected?
Because the 3-day stay in the hospital was deemed not necessary. Right? See, there's a lot behind this, so just these are little points to kind of, you know, little antennas should go up on your head if you're ever in any of these situations. Just make sure you understand what could happen, what is likely to happen, and what you're going to be on the hook for. Okay? So just to go through a few of the things, the different discharge options, acute inpatient rehab, this is your Burke, your Helen Hayes, your Phelps Hospital. I think there's still an acute rehab down at the medical center. Very aggressive short-term goals, okay? An acute inpatient rehab, you're usually there for 7 to 21 days. Could be a little longer if you've had, you know, a spinal injury or some kind of some severe trauma. It could be longer than that, but usually it's like 7 to 21 days. Your Medicare covers 60 days under your Part A. In commercial insurances, it depends on your plan. Some don't have an acute rehab benefit at all. Some plans are 30 days, some are 60, but usually not any longer than 60 for the most part. Always based on medical necessity, always. So you must need that level of care to be able to use that benefit. The services must be deemed restorative. That means by going to acute rehab, they're going to make you better. It's not a maybe, they're going to make you better and more functional. You also have to be able to tolerate 3 hours a day of physical and occupational therapy, which is a lot. Okay, and you need to be able to do that 5 to 7 days a week. So it's like going to the gym for 3 hours a day, 5 to 7 days a week. They can manage any other comorbid conditions that you have. So if you had that, spinal injury, but you also have a heart condition, they can manage that for you there. They have doctors and nurses around the clock. But those conditions should be stable. They are not an acute care hospital. Okay? If something happens to you acutely, they're going to transfer you out to the closest emergency room. You may, when you're finished with your stay in acute rehab, you may need to transition to another level of rehab. So an acute rehab facility may transfer you to a subacute rehab facility or a nursing home for continued rehab. If you go to a place like Burke and you're not able to tolerate their program, they're going to transfer you to a lower level of care in a nursing home for subacute rehab. All right, there's really, from our perspective, no standardized referral format. We send a lot of information from your medical record, your demographic information, your financial insurance information, and your clinical information. That's what we do on our end when we're trying to get somebody accepted to an acute rehab facility. Sometimes we have our physicians speak with their physician so that they can put their heads together and come up with a plan, and that's how people get approved to get into acute rehab.
Is it presumed, if you're accepted, say, for acute rehab, does that presume that there's insurance coverage, or just by basis of,
Not necessarily, because it's really, any of these decisions are really a twofold process. There's the clinical side of saying, is the care appropriate for this individual, clinically speaking, and then is there a payer source? It's a two-step process. So the first step of the process is we try to make the case that clinically this level of care is appropriate. Then we see what resources you have to accomplish that, because you may not have coverage for rehab. It's not in your insurance plan, or maybe your insurance doesn't agree. It still doesn't mean you can't go if you'd like to write a check to Burke. Okay, so we could still get you there, but it's a matter of how it's going to be paid for. All right? The next is subacute rehab, which is in a nursing facility. It's also called SNF rehab. And in this setting, you will get 1 to 3 hours a day of physical, occupational, or speech therapy, 5 to 6 days a week. There's a couple places now that are doing this therapy 7 days a week, but it's rare. Most of them are 6 days a week. You may have a possible need for skilled nursing intervention, so you may need those injections. You may need wound care. They can provide that for you there. Your estimated length of stay is going to be somewhere between 21 to 100 days usually, because you have that 100-day benefit. Again, for short-term rehab, the usual length of stay is somewhere between 14 and 20, because most facilities want to get you out before you incur those copays, if at all possible. You want to get out before you incur the copays, if at all possible, and you're not intended to stay there long-term. You're going to leave the facility. It is very dependent upon your skilled need, whether you can access this benefit, and the medical necessity of the skilled need. So you're going to need the RN, the PT, the occupational therapist, or speech therapy daily. All right? Again, the therapy needs to be deemed restorative. And in New York State, there's paperwork required for admission to a nursing home. You can't just get into a nursing home. It's called a PRI and a screen. That's something that my staff completes for you if you're going from the hospital. If you're going from the community for some reason, which you can for a long-term placement, that paperwork also needs to be done, and then there's individuals in the community that can complete that paperwork for you. PRIs need to be done by nurses. The screen portion, it's a 2-part form, that can be done by a social worker or a nurse. Okay, so you need to be certified to be able to complete this paperwork. All right, and the skilled nursing facility stay will be covered under your Part A. It does require that 3-day qualifying hospital stay to access your skilled nursing facility benefit for Medicare. Then the outpatient therapy, okay, physical occupational speech therapy offered to patients in a freestanding facility, outpatient department of an inpatient facility. So for instance, at Northern Westchester, we have a rehab department. It's currently now located down at Chappaqua Crossings, but you could come there for your outpatient physical therapy. We'd be happy to have you. Depending on the facility, patients can receive treatment that's almost as intensive as acute inpatient, but you go home every day. All right, the level of therapy you're going to get in a skilled nursing facility is not as intensive as what you would get at FERC. But in the outpatient setting, with the equipment that they have, that they can have you work on, it's pretty intensive. Okay, you don't go every day. Usually you go 3 times a week. That's the difference. But the therapy is pretty intensive. It's set up like a real gym. They really work you out. You have a lot of weight training. All kinds of stuff can go on there. So it's pretty intensive. So if you can get back and forth and you can safely be at home, this is a good option if you need therapy. Okay? Co-payments may apply because this is covered under Medicare Part B. You're able to customize your therapy plan to aid in returning to the community or returning to work or maximizing your full potential. So based on whatever your goals are, okay, the therapist in the outpatient setting can work on the specific tasks that you're going to need to do to get back to where you need to be. When I first started in case management, I worked in workers' comp and no-fault arena. And so I had a workers' comp patient one day, was a bus driver, who had an injury, a shoulder injury. So one of the things we had to do to get her back to work was we had to actually go to the bus yard one day, the physical therapist and I. We had to go and measure and examine the bus to make sure that she could handle everything she might need to do on the bus. Opening the doors, opening the roof to evacuate, punching out those windows to evacuate, putting the chains on the tires. We had to examine all the physical mobility she was going to need to be able to return to work safely. And we were able to get that from the physical therapy in the outpatient department. That's how they coordinated her plan to be able to do those things to get her back to work. And she went back to work. Okay, so they can do a lot of creative things in an outpatient therapy setting. Duration of therapy could be short-term or long-term. It really depends. You could go for a couple of weeks. You might need to go for a couple of months. It depends on what the nature of your problem is and how much progress you're making. And continuation of therapy is indicated until you've reached your maximum medical potential. So while outpatient therapy, you still need medical necessity to need physical therapy or occupational therapy, but they can't discontinue it until the therapist has decided you're as good as you're going to get. And that's what this means, maximum medical potential. Okay? You're kind of plateaued, you're probably, we may not be perfect, but if they don't look like you're going to get much better, then your coverage is going to end. Skilled home care. This is home care in your house. It's intermittent. It's short-term. You can have physical therapy in your house as well. And it's provided under the direction of your physician. Okay, the visits are usually made 2 to 3 times a week. One of Medicare's criteria is in order to qualify and access your home care benefit, you must be homebound. Okay, which means you're confined to your home, except for medical appointments, religious worship, in order for Medicare Part A to cover following a hospitalization. All right, so you kind of got to be, which with a lot of elderly people, that's very easy to meet. If they've been in the hospital, they're not going to bingo the next day. So they're home for a little while. Recuperate. All right.
So this is after that 3-day in the hospital?
For home care, you don't need a 3-day stay. The only thing you need the 3-day stay for is the nursing home.
Okay. All right. So this, you just have to go to your doctor and he says you're homebound.
Or if you were in the hospital, we'll make these arrangements for you before you leave.
Okay.
All right?
But you don't need the hospital.
You don't need the hospital. Your doctor in the office could arrange for this also.
Okay.
But you still got to be homebound.
All right.
Okay? So either way, whether you're in the hospital first or you're not,
Yeah.
if your doctor feels you have the skilled need, and because the home care is provided under the orders of a physician. They have to order the home care. The home care is delivered by nurses and physical therapists who operate under the order of a physician. A nurse can't just do things without a physician's order. Everything we do is by physician's order. Okay, so and home care works the same way. Your doctor's got to order it. In addition to the nurse and the therapist, you may be eligible to have some home health aid services if the nurse deems that necessary for your particular circumstance. What Medicare covers, a maximum, is 4 hours a day, 5 days a week of home health aid service. Basically for personal care to help people shower, do a little light housekeeping, that sort of thing. But beyond that, there's no coverage for home health aid service. That would be something individuals have to privately pay for. It does cover durable medical equipment, wheelchairs, commodes, canes, walkers, things of that nature that are deemed necessary for their ambulatory status or for their personal need, like the commode. It doesn't cover things like grab bars on the shower and things of that nature. Those are considered convenience items, believe it or not. For commercial insurance, there's usually a copay for each home visit. A thorough home safety assessment should be conducted to assure safety. That's one of the things we try to do to the extent that we can in the hospital. What my staff will do is they're going to ask you a bunch of questions about the home, the structure, the home. You know, do you have 25 steps to walk up? You know, and can the person walk up those 25 steps? What we have to make sure is if we're sending you back to that home environment, not only can you get in, you got to get out in the event the house goes on fire. Okay? That's what we're trying to look at to make sure that this is safe for you to go to that location. If you can't exit the house down the 25 steps with minimal help or no help, it's not a good idea for you to be there. All right? So we have to look at that sort of thing to be able to meet our requirement of a safe discharge plan. Okay? You need to also be able to get to your bathroom, to your kitchen, to your bedroom. So we've had circumstances where we've had patients who, for whatever reason, had an event of some sort. Now they're wheelchair confined. Well, they're home, their doorways, the wheelchair doesn't fit. They can't go home if they can't get through their doorways to get to the bathroom, to the kitchen, and to the bedroom. So we have to make other accommodations in those circumstances until the home can be retrofitted and make it work. Otherwise, it's other long-term plans. And there needs to be some kind of support system in place to make sure that you have food, that, you know, if you have a problem with the structure of your house, that somebody's going to make sure they call, you know, roof starts to leak, somebody's got to be able to call and get that fixed. You need to have somebody who's going to shop for you, provide personal care, and transportation for medical appointments. So either you need to have a support system that can do that for you. There's some of this we can arrange for you, like transportation through paratransit, if you're able to access that of your own accord. But if you're not, you need to have that support system, because the skilled home care isn't with you 24 hours a day. But the hospital's job is to make sure that you're safe 24 hours a day. So we need to know that either you've got a family member with you, you've hired help, whatever, to make going home a safe plan. So we ask you a lot of questions. Don't be offended. We're not being intrusive. We're trying to make a good, safe plan for you, and we need your help. Okay?
And short term is how long? What's short term?
Short term could be 2 weeks, could be a month, could be 6 weeks. It depends really on your need. In terms of Medicare, it's 60 visits. So moving on to assisted living facilities. Okay, now these may be appropriate for some patients, even on a short-term basis, even though they're a longer-term plan generally. But if we have patients, let's say, who've had a surgical procedure and maybe they're not snapping back as quick as they were hoping, but they don't have any family and they live alone. All right, but they don't really need to go to a nursing home. They just need someone to, you know, maybe help make the bed and make them a meal. Going short-term to an assisted living facility can be a good option for people like that. All right, they're also good long-term options. If mom and dad can no longer maintain themselves in their own home, if they need help with meal prep and maintaining their physical environment, this could be a good plan for them. Minimal assistance with their ADLs, housekeeping, meal prep. One of the criteria is, in most of the assisted livings, you have to be able to mobilize well enough. And that could be in a wheelchair or with your walker, but you have to be able to get to the dining room for most of your meals. That's one of the criteria for assisted living. Okay? Assisted living doesn't want people stuck in their rooms all the time. And they don't have the medical staff to transport you. They don't have nurses or nurses' aides, for the most part, to be able to, wheel you to the dining room. You've got to be able to do that for yourself. Assisted living facilities are primarily private pay circumstances. There's a couple of places in Westchester County that have a couple of Medicaid beds. The Seabury at Field Home, which is over in Yorktown, they have, I think, 4 Medicaid beds in their assisted living facility. The rest of it is all private pay. But if you have that long-term care insurance, that can contribute to part of the cost. The cost of assisted living facilities varies greatly also. Some of them are $3,800 a month. Some of them are $9,000 a month. It depends what you want. You can have a studio apartment, you can have a 2-bedroom. It really depends what you want, what facility you want to be in. But there's a lot of variation from one facility to the next. They provide activities, they'll provide some transportation to doctor's appointments and things of that nature. And you're really living with help, but independent. You're free to come and go. It's not like in a nursing home where you can't leave. All right, you're free to come and go in these facilities as long as you're safe to come and go. Yes?
Does Medicare pay for any of that?
No. Nope. Unfortunately not. And this is what people like me are hoping in the future of healthcare reform, that, Medicare right now spends all their dollars on the back end. After something terrible's happened to you, they'll pay. Well, we could prevent a lot of those terrible things from happening if we took care of people as they begin to decline and, paid for that home health aide in their house before they fall down and break their hip. Maybe that home health aide will prevent them from falling down and breaking their hip. We're not there yet. There's talk about it, but the rules have not changed to reflect any of that. But I think as people think this through, if you're into calling your legislators and making suggestions, I would urge you to do that. The whole thought process has to change to really pay for what people need most that will prevent the bad stuff from happening that costs a lot more money on the back end. Discharge options for the other long-term are custodial nursing home. So we talked about going to a nursing home on a short-term basis. You also can go to a nursing home on a long-term basis where you physically relocate to the nursing home, okay, and you live there. This is not something Medicare pays for either, all right? It's private pay or Medicaid. Most facilities, depending on what your financial circumstance is if you go to a nursing home on a short-term basis with Medicare paying, and it's determined, or you decide at that point, you really didn't progress well enough to go home, and now you're going to stay. They'll work with you to do the Medicaid application, to apply for the Medicaid, provided you meet the financial criteria for that. Otherwise, you have to pay out of pocket until such time as you do meet the Medicaid criteria, and then they'll work with you to do those applications. And then Medicaid will pay for you to stay in the nursing home for the rest of your life. Okay? Medicaid will also pay for custodial home care if you meet the financial qualifiers. And that's a program called Nursing Home Without Walls. So if you otherwise meet the criteria to be in a nursing home long-term under Medicaid, if you have a home and you have the support services and you can have a live-in home health aide with you and safely reside in your own home, they'll pay for that instead. But again, it all depends on the financial qualifiers. Okay? And none of the Medicare rules apply to this scenario because Medicare is not footing the bill. So the other thing under custodial home care is the aides. You can have a live-in aide or you can hire them for shifts for 8 or 12 hours. They're either private pay, Medicaid, or the long-term insurance will contribute to that. But there's 2 different kinds of home care aides, so to speak, that you could get. There's a personal care aide, and then there's a companion, and they can do different things. The personal care aides can actually assist you with bathing, so they can actually take you by the hand into your bathroom and help you get in the shower. They can help wash you if you need that. A companion cannot. They can get your bathroom all set up, make sure you have everything within reach, help walk you in, but then you're on your own. They'll help you back out, but they can't physically wash you. The personal care aide functions under the direction of a nurse. So if you have a personal care aide in your house, there's going to be a nurse of some sort that's overseeing that case. You may only see her once a month. She's not there to provide any skilled nursing care. She's there to supervise the aide. The companion functions under the direction of the patient or family. They don't have a higher authority that they're reporting to. Personal care aides cannot administer medications. They can remind you to take medications, but they can't physically put them in your mouth. A companion can if you want them to. Personal care aides are not able to drive your loved one anywhere, but companions can. All right, so depending on what you need, you may prefer to have or some combination. Okay, if one of the issues is, you got mom and she's home and she needs help with bathing and all of that, so you're going to get the personal care aide, but maybe 2 days a week you're going to have a companion also because she's got to get to the doctor's appointment, she's got to get to the eye doctor, the podiatrist, and you're working, you can't do it. So make some combination of plans to meet your needs. And the last thing, which I won't elaborate on because Hal did a great job last week, is hospice. It's appropriate when patient and families have rejected aggressive measures and have opted for comfort, palliation, and symptom management. The benefit is 210 days, that's 6 months. They don't kick you out if you don't die in that time period. But in your physician's judgment, he's got to sort of say, to the extent he can without a crystal ball, that the estimated life expectancy is 6 months or less. The patient or their family on their behalf must consent and agree. You actually have to sign on to hospice. You have to sign a consent form. And as I spoke of earlier, it can be inpatient or outpatient. Inpatient is usually fairly short term, either at the active dying phase or for symptom management and control to be able to get you back home and better control with pain. All right, so I think the best advice I can really give you at this point is on the importance of long-term planning, whether it's for yourself, whether it's for your elderly parents. Know what your resources are, know what you're going to have to work with, all right, and plan ahead for what you want. Some people, and even earlier when we were talking, some people were saying to my mother, we never wanted to go to a nursing home. And if that's, if that's really important, it would be really hard to not respect those wishes and put her in a nursing home. She never would make that decision for herself. So know what people want. And knowing what they want, know what resources you're going to have to make plans that are going to be applicable, okay? Understand your medical conditions and your prescribed treatments, and don't be afraid to ask your physician or your nurse. Become their worst nightmare. If you don't get it, say so. I'm serious. We have a responsibility to make sure you understand. And as healthcare professionals, we're very busy. We walk in and out of your room all day. We're giving you a lot of information. We have a lot of things to do. And just because I told you something doesn't mean you get it. If you don't get it, tell me. It's my job to make sure you get it, not just to make sure I told you. Okay? Identify your wishes with your proper long-term planning and your identification of an advocate. Do your healthcare proxy, your living will, as Hal and Victoria spoke about. And then make sure somebody knows what your wishes are. Don't just do those forms and stick them in a drawer somewhere. All right? Make sure that people know what your wishes are. If you've chosen a healthcare proxy, make sure they know who they are. All right? I know Charles last week said give a copy of your healthcare proxy to your pastor. That's a fantastic idea. Fantastic idea. All right? A lot of times we can't get to those documents in the hospital when we need them. A lot of times I'm calling lawyers all over the county to say, I'm calling because I have this patient. Do you have a copy of a healthcare proxy? They tell me there is one, but no one can find it. All right, so keep copies of them. Make sure they're in safe places.
Do you need an original, or can you have a copy?
For the healthcare proxy, no. And actually, when you come to the hospital, each time you're admitted to the hospital, we're going to ask you if you have a healthcare proxy. If you tell me you do, but you don't have it with you, I'm going to ask you if you would like to write a new one, so that I have one on the chart right then and there. You don't have to. You can bring in the one you have from home if you can get to it. But we'll give you the option of doing a new one each time you come into the hospital.
No, but you don't need the original. You can
don't need the original. A copy is fine. The other thing, and probably when the attorney speaks in a few weeks, he'll probably go into this more, but the thing you should do is when you do these documents, review them periodically. Because you do them, they're done, you put them away. Pull them out every year or so. Review them, make sure they still reflect what you really want, initial it with the date, And then that way, we always know that it's current. You know, a lot of times people will produce healthcare proxies, and they're not the current one. You know, you have one son that flies in from Illinois with this piece of paper, and then you got another one coming in from over here with another piece of paper, and they're not the same because Dad changed who his healthcare proxy was. But if Dad didn't initial it or date it, it's hard for us to know which one is the real one. So make sure that you review them, you update them, and that they're kept in safe places and other people can get to them if you can't get to them yourself. Okay? And seek advice. Don't be afraid to ask questions. Like I told you in the beginning, I work at the hospital. I take care of the patients in the hospital, but our hospital's for the community. So even if you're or your loved one isn't in the hospital, but you need help, call me. I'm happy to help you. I'm happy to talk to you. You can come in and sit down with me. I'll talk to you on the phone, whatever. Happy to help. Okay? Some other resources you may want to access, and there's information in each of your packet about this. Elder care attorneys. Okay, there's ways to be able, elder care attorneys are sometimes invaluable if you have assets and resources. They can help you preserve those if you're going down the path of long-term care. Very important to try to do that. You don't want to be paying your life savings to a nursing home. If there's a way to protect what you've earned, what you've gathered over your life, or whoever you'd like to leave it to, an elder care attorney is the person that's going to be able to help you do that. There's geriatric care managers in the community. These are people much like myself. Some of them are nurses, some of them are social workers, but they will help you manage your elderly loved one in the community to do all the things we just talked about and plan for long-term care, home or in facilities. Financial planner, okay? Depending on where you are in the phases of things, this could be a useful resource to you to invest wisely to be able to make sure that you have what you need going down the line. Caregiver coach support. If you're taking care of somebody, don't forget to take care of yourself. You're no good to them when you fall down, and then they're all alone. Take care of yourself. We have an excellent caregiver program at the hospital. You don't have to have a patient in the hospital to access it. It's a fantastic program. If you have experience with caregiving, we could use you too, okay? Westchester County Department of Senior Services has actually quite a few programs, and I gave you some information there too. Not sometimes difficult to access, but keep trying, okay? They're understaffed like a lot of people, but they have some excellent programs. May Carpenter, who is the commissioner for senior services, is an advocate beyond belief for senior care. She's a wonderful woman. And then you have your hospital case management department, which is me. Okay, so what would we ask you guys to do? Understand that the hospital can only admit patients who are deemed to require that level of care. You get somewhat in some adversarial situations when, you know, you can't manage mom at home anymore, but we can't really admit her either, so it's a very difficult circumstance. Understand that discharge planning begins on admission. Know what your available benefits are for your hospital, your nursing home, and community, and they're not endless, remember that. Know what's not covered and anticipate what you might need. Plan ahead and make a long-term plan that considers your finances, your resources, and your wishes. Appoint a healthcare proxy and a power of attorney. Cooperate with the hospital staff to coordinate the best plan that meets your needs within the confines of your circumstance. And always consider a combination of short-term, long-term plans, community resources, paid resources, and family care. And again, seek advice. We're there to help you. Okay, this is one of my favorite quotes because it kind of just sums it up. Right? Failing to plan is planning to fail. All right, very stated wisdom in my opinion. All right, any more questions? You're very welcome.
You feel the same way that I do. We've learned more than what we wanted to. But at any rate, and happy Easter to all. In your packets, Katie said that she's provided a list of various nursing homes, skilled, We've also handed out to you a list of those who are part of the team of facilities in the area that we're familiar with. It's not necessarily an endorsement, but we know that some of our members have had good experiences. So that's why There are two different lists, all
Are they
right?
both in the packet?
Our list, Karen gave to you as you entered,
Oh, okay.
all right? That's the list of facilities that your team is aware of and have had experiences with, okay? Can't thank you enough,
My
Katie.
pleasure, thank you
Just
for having me.
remarkable.
Thank you.
Our next gathering will be April 21st, when we will have a lawyer and financial planner will be with us to deal with the additional questions that we're going to need to face as well. Thank you all for coming.
Do you see how's the video going to be?
I don't know. I think we're going to put it on the website.